Hello, everybody. This is Dr. Verdialis from the Georgia office. So today I will, as usual, start with a few cases that I encounter throughout the week and that might help somebody in this evening. So I wanted to talk about a case of a tool reversal that failed. She ended up getting pregnant on the left tube, and then losing that tube, and then the other tube became blocked after that surgery. And right now she's dealing with hydro hydrosalpinx, meaning that the right tube is full of liquid, and at the same time there's like some free fluid in the pelvis that was described by the radiologist as loculations. So her question was, can I transfer, and what are the chances that she wants to do a fresh transfer with that right hydrosalpinx and that loculation in the posterior area. And so we had this discussion actually this morning. And one, can the transfer work? Yes, it can. The uterus look good, lining look good. But what is the success rate? The success rate is actually a lot less. And because of all the inflammatory process that's happening in that pelvis, also a swollen tube full of gunk, it's a reservoir for infection and inflammatory proteins, cytokines, interleukins, etc., that could be detrimental to a growing pregnancy, or even the process of implantation and creating inflammation in that uterus. So we had that discussion, and we noticed that at her baseline, and we had that discussion then. And we started her on Mucinex and on triple antibiotic, so metronidazole, doxycycline, and fluconazole, and with the Dosinex. The uterus today was her 7th day of estrogen today was her 7th day of stimulation, because she's actually going through a retrieval, and the lining looked trilaminar, and the uterus again was good, but there's the question of, will a fresh be successful? So my recommendation to her was, why don't we go in and remove that tube and clear whatever fluid is in there. Sometimes after having an ectopic, especially if it's a rupture ectopic or pelvic inflammatory disease or even endometriosis, you can have pockets of inflammatory fluid, and it's better out than in. After an extensive discussion with her, she wanted to actually move forward with a fresh transfer. And if that fails, then she was going to do the laparoscopy after that. So several things on that. One, this is your journey, okay? And even though we make recommendations to give you the best success rate, the chances of a successful pregnancy, ultimately, it will be your decision unless there is a significant impairment or there's a medical contraindication, okay? So the reason I wanted to bring her case up is, one, I know that a lot of you encounter a lot of pushback, as you're trying to do certain things. And there is leeway to get what you desire, as long as there is not a significant medical contraindication for it. So that was one of the cases that was interesting today. And then the second case, which was a lot, that one definitely we canceled because she's a diabetic. She had donor eggs, embryos are ready, last time that her hemoglobin A1C, or the diabetic marker, was checked, it was 7 a few months ago. And when it was checked at baseline, it was 8.8. So there's a medical contraindication to transfer. So we canceled the cycle. And luckily, she understood the reasons for it. Okay, I always like to share a few cases. Let's see what you have for me tonight. Any recommendations the night before transfer? One, you want to be as relaxed as possible. I would meditate, honestly, visualize. For those of you that have transferred with me, I always say the same story. Visualize your uterus as a pot, and your lining is the black soil, and then the transfer is that little seed that's going to be implanted, and it's going to grow into a beautiful pink or blue flower. So really getting that mindset, and that's it. And then just show up and be beautiful. I know that most doctors say you can travel the same day. I prefer that you guys travel the next day, because implantation happened within a few hours of transfer. So those first 10, 12 hours are critical. Either it implanted or it didn't. So I would kind of take it easy for that day, avoid travel if possible, and then leave the next morning. Okay. 47, AMH of 0.8. Am I out of egg reserve? Surprisingly, at 47 with an AMH of 0.8, it's fantastic, and you should definitely celebrate that. And are you out of egg reserve? You'll have low reserve. You can probably work with that. With an AMH of 0.8, usually on the younger women, you would get about 4 to 6 eggs. So we would have to see how you respond. Letrozole Ovidrel time intercourse cycle versus a letrozole Ovidrel IUI cycle, chances to get pregnant. It really depends on, one, is there any male component? You know, is the semen analysis like 100% normal? Are we dealing with both tubes open? Okay, that's going to be really, really important as well. IUI, I like calling it super sex. You fluff up the sperm, get rid of the abnormal ones, and give them a heads up, a head start. So it increases chance, like having sex at home, it's 8 to 10%, and IUI goes to 20. So it does improve chances of getting pregnant, but I mean, IVF is the best technology we have, and it sits at the national average of 50%. I have an embryo listed as undifferentiated. What does that mean? That it arrested. Hello, everybody that's joining me. Always nice seeing you all. So I am at the Georgia office the majority of time. I occasionally will go to Syracuse. And that's a question that everybody asks, especially on that first consult, is like, are you going to be my doctor? So you are always welcome to circle back with me. The Atlanta number is 770-266-3930. And you are always welcome to reach me through Facebook. It is actually the best way to reach me. Maribel Verdiales. My last name is very unusual, so I'm very easy to find. If you need to follow up with me, or you want to do one doctor in terms of opinions, however, chances that I'll be doing your retrieval and your transfer, it has to be divine intervention, because again, it's pretty random when I go up to Syracuse. Okay. When do you stop medicine like prednisone and LDN? So let's say let's say you did your transfer and it failed, you want to wean off the prednisone. So if you're on, let's say, 10 milligrams twice a day, then you're going to go to 10 milligrams once a day, every other day until you can stop. I would stay on the LDN. It is beneficial for the next round of whatever treatment you're going to do. A lot of people feel really good on it. If you're having side effects on the LDN, maybe you can try a lower dose. Some people don't tolerate the 4.5 as well, and some people get insomnia from it. So then you could try it in the morning and see how you do with it. LDN comes in 1.53 and 4.5. If you stop, especially the prednisone, and if you've been on it for a few weeks cold turkey, you might get a headache, lightheadedness, just feeling a little weird. With PCOS, looking to treat with letrozole trigger shot, is IUI superior to natural conception? Not necessarily. A lot of time PCOS patients just need a little help. And so I would try time intercourse first. You can even, depending on your age and your labs, you can do a few months of, minimal monitoring. You can do day 21 progesterone just to make sure that you are ovulating and you're making enough progesterone. You can do monitoring and really time when to trigger and when to have sex. And then depending on how you do with all of this, startup treatments, then you can, move to IUI. Is it better than natural conception? It does increase chances of pregnancy by 10%. So yes, but you don't really, if the problem is that you're not ovulating, you don't really need to start at IUI. Okay. Do you recommend microdose Lupron protocol on 45, intrafollicle count of 0.7, AMH of 0.64? And so you had lead follicles. You can do a microdose Lupron. I usually, with people, show up with like a lead follicle at baseline. Then I try to do several things. My favorite protocol is actually to get a letrozole cycle before the actual treatment cycle to hopefully have a more natural, more robust ovulation, and then have a more even baseline on the round that you're going to go through IVF. And then the other thing is you want to be treated early. So you want to have like a day 1 or 2. If you show up at baseline, even after doing that and it didn't work as planned, then you can do like a Lupron luteal phase to have better control of how those ovaries work. If I had gone through all the workup at my local infertility doctor and they told me IVF is our option due to male infertility, financially we decided CNY. So in general, we'd like to see results within the year. So that way we can serve you better. Okay. So especially your AMH and some other stuff, you really want to, see where it's at, especially if you had a low reserve to start with. What is the % chance of IUI on first try with irregular cycles? If you don't time ovulation and IUI, then you're not really doing much. You really have to, once we go into IUI, we do strictly monitored cycles for the most part. Some people can do ovulation monitoring at home. I don't really like doing that because you are spending like that extra level of money and effort to do IUI. So why not max out the possibility of success? Sex before and or after FET when? You can have sex before. I would refrain from sex the night before and probably the day off, but after that, it's all game. Okay. Experiencing PCOS and male factors, success rates with both male and female infertility. it's going to depend on what are we dealing with and how severe that is. Are we dealing with age factor? Are we dealing with severe male factor? Are we dealing with decreased ovarian reserve at this point versus the very, very resistant PCOS? So that's going to determine how successful you're going to be. We do see a lot of our patients having compounded issues that it's causing their challenges with fertility. And we see a lot of success rates with a combination of female and male issues. So those are my 2 cents. Awesome. Well, thank you all for your questions. These are really good questions. Okay. Hello, hello. Oh my God. We have a happy share. So we have Miss Dariana Trinidad. And she is 36 weeks pregnant with her rainbow baby. So congratulations. Okay, so Danisha, does your clinic work with persons living outside of the United States? I live in the Caribbean. How would you find out costs? Yes, we are a global fertility clinic. I have patients coming from the Caribbean. I've had patients come from Spain and South America. And, you know, I mean, there's a few challenges in terms of prescriptions and stuff like that, but we work with people from Canada all the time. So the pricing would be the same, which is pretty economical compared to most of the world. And then a lot of my international patients, either they get, you know, we do a collaboration where they can have a local doctor write the orders for the ultrasounds and the blood work. And then they get meds where they're from. We kind of write a list of what we need, and then they have a local doctor write the prescription. Sometimes they have family in the United States, and then we use their address to send the prescriptions, and then that family member will ship them the meds. So there are many ways of skinning the cat. Oh, Leslie, that's so sweet, sweetheart. I do what I do because I love it. There's that extra priceless satisfaction that, you know, makes my life 100 times better too. So I'm glad that you're doing a lot better. Can you do an IUI with a tubal ligation? No. You need working tubes to get an IUI done. Depending on how the tubal ligation was done, you could try to have a tubal reversal, and if your tube's okay, then you'd be able to do IUI. 43, 2 miscarriages, positive for anticardiolipins, AMH of 0.5, female anatomy normal, sickle trait carrier. Which protocol can I have done? All right. So if you have a coagulation issue and the antiphospholipid syndrome, it's a combination of coagulation issue and inflammation process, then I would put you on an immune 2 or 3, probably like a 3. And depending on whether your tubes are open and your partner's semen analysis, we can do hyperovulation with IUI, and then still use a level 3 immune protocol for you with Lovenox and prednisone and potentially intralipids, baby aspirin, Claritin, or we can go into IVF. And then with an AMH of 0.5, at your age, everybody responds a little different. We're hoping, if we have to do IVF, to get 3 to 4 eggs. There's a point in this in this game when you're hitting your 40s and your AMH is slow, that sometimes hyperovulation and IUI might actually be a better choice, just because you're not going to get a lot of eggs. And when you go through the retrieval process, you're putting those eggs through a lot of stress. You're pulling them out, you keeping them in a lab, you're fertilizing them artificially. So sometimes kind of thinking outside the box and then using IVF meds, but then switching to IUI might actually also be a good choice. All right, what would you recommend for an even growth of follicles during stim? The best thing is to have a good baseline. And like our friend was discussing, like I was discussing with the other lady, if you don't have a good baseline and you have a lead follicle, in the IVF world, playing catch up is not the best scenario. So either we can do a luteal phase start, meaning just provoke ovulation and start a few days later, or just allow yourself to just go with that cycle, then maybe do either a letrozole cycle, the next one, so an ovulation induction, then go into a stimulation for retrieval or IUI, or use that Lupron, luteal Lupron, day 21. Okay. All of my labs checked out perfect. AMH is 2.85. We got all of our labs. SSG done 6 months ago. He has done 2 semen analysis. Morphology is 2%. Okay. So that's kind of a challenge when you have morphology issue, because then you're going to have a lot of abnormals. So depending on how high the count is, you could do IUI, but you're going to lose a lot of sperm. And then I wouldn't do a lot of IUIs. I would definitely, when I have a male factor or a female factor, I get a little bit more aggressive with the IUI protocols. But I could do, I would say 1 to 3, no more than 3 before I jump into IVF. How many follicles should you get with an AMH of 1.93, age 39 at retrieval? Everybody's a little different, but the ideal cycle, they call it, is like 20 eggs at 39 with an AMH of 1.93. We could be dealing with about 10 to 12 eggs. Okay. What time frame do you recommend resuming fertility treatment after a loss at 6 weeks? Just jump on it right away. There was an observational study from the 50s that showed that women are kind of hyper fertile the 6 months after a pregnancy has ended, regardless of how that pregnancy ended: miscarriage, abortion, ectopic, or a birth. Okay. Okay. Can taking male supplements for fertility for a year be bad? Absolutely not. You're building your body. For those of you that work with me, I am a naturopath as well. So I believe in a very integrative approach to life, period, not only fertility. Anything that will add to your biological reserve, it's going to be a gain in more than one level. Is there any way to prevent ectopics when already pregnant? No. I mean, once you're pregnant, it doesn't really matter where the pregnancy is, because where it is, it is. Preventing ectopics in the future, it depends if there's any tubal compromise. If you've had an ectopic, it puts you at risk for ectopic. If you had any infection in your pelvis, you're at risk of ectopic. If you had endometriosis, puts you at risk of ectopic. If you had any previous tubal surgery, puts you at risk of ectopics. Have you seen more success with fertilized eggs not fully developing to blast until day 6, but 7, fresh versus transfer? No, I haven't seen anything significantly different for a blast that doesn't fully develop to day 6. We do have a lot of very successful babies that come out of day 6 and 7. And how do I feel about IVIG? Does it does it have a proven positive impact? A lot of the stuff that we do has some evidence, some anecdotal evidence. Some of it, there's more research coming out, like the PRP stuff, even though every now and then somebody says that it works or it doesn't work. In the clinic for the IVIG is really more reserved for people that have a known autoimmune disorder or have multiple issues, because it tends to be very expensive. And I have seen people get pregnant with severe autoimmune issues using IVIG. Do you recommend the antihistamine protocol before doing stimulation for IVF? I do. It's not my to go first, but if you have any autoimmunity and any inflammatory processes, I would definitely include that as part of the immune protocol. I had a mini IVF cycle, 1 egg, but it didn't fertilize, AMH of 0.2. I turned 37 last April. Do you recommend trying mini IVF or egg donation? That's a toughie. One, with an AMH of 0.2, you're looking at 1 to 3 eggs per cycle. I would try to do some priming. I would try to, get rid of grains, wheat, corn, soy, oats. I would try some supplements, human growth hormone, even ACG, low dose ACG priming, PRP, fantastic. So I would try to do that first before jumping into another cycle. But and it's a very personal thing as well. And this is your journey, so it's kind of, you have to be ready to jump into egg donation. Now, donor eggs will be your fastest and easiest way to get a baby, but you have to be ready in your heart for it. So whether you jump into that, there's no right or wrong answer. If you wanted to just, if it was too much for you to go through this experience, then yeah, go ahead and go into egg donation. It's going to make your life a lot easier. Just be sure that you are, mentally and emotionally ready for it. And if you wanted to try again, then I would definitely do some priming. Awesome. Okay. All right, so this is a good comment, because I'm gonna use it. Thank you, Susan, for sharing your concern, which I hear it all the time. So Susan is saying that she has only 1 normal embryo and she is terrified of transferring because she could lose it. So the fertility journey, I call it a thrialong, it's beyond the marathon. So, and you have to keep your eyes on the prize, and the prize is having a family. It's having a baby, whichever way God gives it to you. So you can't go through this process feeling like being in this like fatalistic mode. Oh my God, if this transfer doesn't work, my life is over. Or, what if I don't get any eggs of my own? So you have to take it in a lighter way, because otherwise it's going to be very heavy on your heart and it doesn't serve anyone, especially you. So let's play devil's advocate. Let's say that 1 normal embryo is a failed transfer. It happens all the time. People think that by doing genetic testing on the embryos, it almost guarantees a pregnancy, and it doesn't. And then they feel kind of shocked when that normal baby doesn't stick. So, you can either, depending on your scenario, you can do donor eggs, you can do donor meaning you can still do IVF and buy a few donor eggs as a backup, plan. There are always choices. As long as there is life, there is hope. Okay. And you have to keep telling that to yourself and don't beat yourself up. It's not like this is the last chance to do this. Okay. 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 I am 29 and my AMH is 0.32. How many eggs do you think I would get? With an AMH of 0.32, you're looking at 1, 2, 3 eggs. I would seriously encourage, especially you're 29. So on the younger crowd, I see those AMHs bounce back a little better than the older crowd. So I would do priming 1 to 3 months. I use a lot of glandular therapy. I recommend a company called Standard Process. That's the one that I personally take, and I've seen really good results with that. And then PRP, you're doing the diet. That's fantastic. CoQ10, a food-based vitamin E. It's going to be really good. Inositol, if there's any concerns with sugar handling. So I would do priming before I jump into IVF. Okay. All right, people. I know that I see that you have a lot of questions and I appreciate you all. If you have specific questions for me about your case, feel free to reach out. If it's something I can answer right away, I will. Otherwise, I will get you on my schedule as soon as possible and we can share some ideas. May you all be blessed and I will see you guys in 2 weeks. Bye-bye.